Hello students, welcome to IURH. So in the continuation of the series of extrahepatic biliary apparatus, today we are going to discuss about the clinical anatomy of extrahepatic biliary apparatus. So let's get started. First we'll discuss about biliary obstruction. So what is biliary obstruction? It occurs when passage of bile into the duodenum is blocked. When the passage of bile into the duodenum is blocked, it is called as biliary apparatus. It may be intrahepatic or extrahepatic. Intrahepatic means it can occur, the blockage can occur inside the liver or also outside the liver. It possible causes are, first is gallstone. So the blockage can occur due to the presence of gallstones in the apparatus and also due to the cancer of head of pancreas. So what happens here? Due to the cancer of head of pancreas, as you can appreciate here, this is the head of pancreas. So if there is the carcinoma of this head, there will be a compression of bile duct. It will cause the compression of bile duct. This bile duct is compressed, which will lead to the obstruction and it will create a biliary obstruction. So these are the possible causes. The first one is the gallstone and the second one is the cancer of head of pancreas. Then after the obstruction, what exactly the pathophysiology occurs here? That the blockage of bile flow will lead to the backflow of the bile in the biliary tree. There is a back pressure in the biliary tree which leads to the accumulation of bile constituents in hepatocytes and blood. The bile constituents gets accumulate in the hepatocytes, the cells of the liver, and also into the blood. And when it enters the bloodstream, that is when the bile constituents enters the bloodstream, it will causes different clinical conditions such as obstructive jaundice. So in obstructive jaundice, there is yellow color of skin and sclera and also dark urine. So this happens because of the presence of bile constituents in the bloodstream or in the blood. It causes yellow color of skin and sclera and also dark urine due to the presence of bile in the urine, which is called as bilirubinuria condition. And also there is symptom of pale stools, which means the stool become pale, it lost its natural color. So the bile present in the intestine gives the stool its natural color, natural yellowish color. And when the bile is not present in the intestine because of the obstruction that is happening here, because of the biliary obstruction, the bile cannot reach the intestine. It will lead to the pale stool because the stercobilin pigment is present in bile, which gives the stool its natural color, the yellowish or brownish color. And when the bile is not reaching the intestine, the stercobilin is not getting mixed with the stool, and so the stool became pale. Okay, so the in obstructive jaundice we see these symptoms such as yellow skin, yellow colored sclera, dark urine, or also pale stool. The second condition that we see is pruritus. Pruritus is there is the desire of itching to the person. The person desires to scratch or itch. This happens due to the bile salt deposition in the skin. The bile salt deposits in the skin, which will lead to the condition of pruritus. And the third one is the steatorrhea. Steatorrhea means excess of fat in stools. So as we know that the biliary, there is a biliary obstruction, so the bile is not reaching the intestine, which will lead to the reduced bile in the intestine. So that will lead to the fat malabsorption. The fat is not absorbing well, or not at all absorbing because of the absence of bile. So this will lead to the condition of steatorrhea, that is excess of bile in the stools, sorry, excess of fat in the stools. Okay, so biliary obstruction is the passage of when the passage of bile is blocked. Okay, it may be intrahepatic or extrahepatic. The causes includes gallstone or CA of head of pancreas, and it will lead to the condition of obstructive jaundice, pruritus, and steatorrhea when the backflow of bile occurs and the bile enters into the bloodstream. It will result into these conditions. Okay, Next one is the endoscopic retrograde cholangiopancreatography, which is also called as ERCP. So what is ERCP? It is the therapeutic or it is used for therapeutic or investigative purpose. It is an imaginative technique which is used for the assessment of bile from the duodenum. Assessment of bile duct from the duodenum. In, in ERCP, we do the assessment of bile duct through duodenum. So what exactly happens here? Here patient is kept nil by mouth for about 6 to 8 hours, and the most important thing is informed consent is taken from the patient. Then after that sedation or light general anesthesia is given to the patient, and the patient is positioned in the left lateral or prone position. Then a side viewing duodenoscope is passed through mouth, as you can appreciate here in this picture. The side viewing duodenoscope is passed first through mouth, then esophagus, then it reaches stomach, and then it enters the second part of duodenum, as you can appreciate here in this picture. Then it enters through the pylorus into the second part of duodenum. Okay, here it is entering into the second part of duodenum, and then the endoscope is positioned opposite to the major duodenal papilla. So we have already discussed in the previous lectures what is major duodenal papilla and where it is located or situated. So the endoscope is positioned just opposite to the major duodenal papilla, which is also called as papilla of Vater, and then after that the catheter is passed. Okay, after that the catheter is passed through that endoscope into the bile duct or into the pancreatic duct. So the catheter does selective cannulation of common bile duct or pancreatic duct. Okay. This cannulation is done through the sphincter of Oddi. We have already discussed in the previous lecture that there is a sphincter present here, which is called as sphincter of Oddi. So the cannulation is done to this sphincter of Oddi, and then after that the radio opaque contrast. After the cannulation, the radio opaque contrast is injected into it. Okay, the radio opaque contrast is injected retrogradely. That means against the normal flow of the bile. The normal flow of the bile is in this direction, and the contrast is injected retrogradely, means opposite to the flow of the bile. Okay, now this contrast outlines the structure of the apparatus, which includes common bile duct, hepatic duct, and gallbladder, and also pancreatic duct. Okay, so what this contrast does, it outlines the structures of the apparatus including common bile duct, hepatic duct, gallbladder, and pancreatic duct, and it shows the abnormality present in the apparatus such as strictures, stones, dilatations, or any tumor or any other anatomical anomalies present in the apparatus is shown through this contrast. Okay, so this is the process of ERCP. It is used to uh, visualize and treat the disorders of biliary and pancreatic duct. Okay, it does not only used to visualize, but it is also used as a treatment for the biliary and pancreatic duct disorders. Okay, the next one is the humoral control of the gallbladder. Humoral control of the gallbladder. So what is humoral control of the gallbladder? It is the physiological process. It includes a contraction and relaxation of the gallbladder, which are influenced by the hormone, and that hormone is cholecystokinin pancreozymin hormone. Okay, cholecystokinin pancreozymin hormone, which is released from the eye cells of the duodenum, which are released from the eye cells of the duodenum. So what exactly happens here? When fat enters into the duodenum through the ingested food, when the fat enters into the duodenum, what happens? The eye cells of duodenum release this hormone, which is the cholecystokinin pancreozymin hormone, and the hormone goes into the bloodstream, and then from the bloodstream they travel to the gallbladder and also to the sphincter, and there they causes the contraction and relaxation of both the gallbladder and the sphincter. Okay, so when there is contraction of the gallbladder, the bile is released from the gallbladder and it passes through the duct, bile duct, or through the sphincter, and then reaches the duodenum to digest the fat present into it. Okay, it causes contraction of the gallbladder and also dilatation of the sphincter so that the bile can flow from gallbladder into the duodenum to digest the fat present in it. Okay, moving on. Next one is the Hartmann's pouch. Hartmann's pouch is the outward dilatation of the posteromedial wall of neck of gallbladder to form a pouch. So what it is? It is the outward dilatation, as you can appreciate here in this picture. It is the outward dilatation of the posteromedial wall of the neck of the gallbladder, and it forms a pouch. And this pouch is called as Hartmann's pouch. Okay, this pouch is not always present. It is a pathological as well as anatomical variation condition. Okay, so what exactly happened here? The gallstone gets impacted at the neck of the gallbladder. Okay, so when the gallstone get impacted at the neck of the gallbladder or in the cystic duct, okay, or it can also happen in the cystic duct or get impacted in the cystic duct, this causes partial or complete obstruction to the bile outflow. The bile cannot go outside. It causes obstruction to the bile outflow, and the obstruction lead to the bile stasis. So there will be a bile stasis, that is the bile becomes stuck in the gallbladder. It cannot go outside because of the presence of gallstone here. So it will lead to the chemical irritation and also infection of the gallbladder, and the gallbladder wall become edematous. The walls of the gallbladder become edematous and also inflamed, and it becomes weak, especially near the neck of the gallbladder. Okay, especially near the neck of the gallbladder. So in this condition, the continued bile secretion is occurring. So the continued bile secretion against the obstruction. See, there is obstruction, but there is also continuous bile secretion or bile releasing from the gallbladder. So in this condition, due to the continuous bile releasing against obstruction, there is raised in the intraluminal pressure within the gallbladder, and this pressure is maximum at the neck region. Okay, this pressure is maximum at the neck region. Intraluminal pressure is maximum at the neck region where the stone is lodged. So due to the raised pressure and weakened inflamed wall, the mucosa and submucosa herniate outward through the muscular layer, and this produces this outpouching of the gallbladder, which is also called as diverticulum of the gallbladder. Okay, so what is happening? Due to the increased intraluminal pressure, especially near the neck, the wall of the neck is becoming edematous, already edematous and infected wall of the neck became weakened, and due to that the mucosa and submucosa of the wall of the gallbladder, or especially the neck of the gallbladder, herniate outward through the muscular layer, which produces the outpouching. Okay, which is producing the outpouching. So it lead to the formation of Hartmann's pouch. It one thing you have to keep in mind, that it is more frequently occurs in elder patients, and this Hartmann pouch is directed downward and backward, and it is developed due to the cholecystitis. As I have already mentioned, there is inflammation of the wall of the gallbladder, which is called as cholecystitis, also due to the gallstone, So due to the presence of gallstone at the neck of the gallbladder, this condition starts occurring, and also there is mucosal herniation. So all this condition together is responsible for the formation of Hartmann's pouch. So the clinical relevance of this is gallstone may lodge in this pouch, we have already discussed, and there is also formation of cholecystoduodenal and cholecystocolic fistula. So as this pouch grows, as this pouch grows or herniate outward, it will fuse either with the duodenum, which is very closely related with this structure, and also with the hepatic flexure of colon, which is also present here. Okay, hepatic flexure of colon, which is also located very close to this structure. So the outpouching increases and fuses with these two structures will lead to the formation of fistula. When it fuses with duodenum, it is called as cholecystoduodenal fistula, and when with the hepatic flexure of colon, it is called as cholecystocolic fistula. Moving on, next one is the cholecystitis. Cholecystitis is inflammation of the gallbladder. So the inflammation can be, or the cholecystitis can be of two types. First is acute and second is chronic, and it can also be of two types, calculous and acalculous. When I say calculous, it is occurring due to the gallstone, and when I say acalculous, it is occurring due to the bile stasis. That means the bile is stuck in the gallbladder, which will lead to the formation of inflammation. So what happened here? There is a pain over right hypochondrium, which radiates to the inferior angle of right scapula and right shoulder. So there is pain in the right hypochondrium, which will radiate to the right shoulder and also to the inferior angle of right scapula. So why this is happening? Why there is referred pain or radiating pain? I have already discussed in the previous lecture. Kindly go through that lecture to understand it better. Next, there is Murphy's sign is present. What is Murphy's sign? Murphy's signs when we are palpating the upper right quadrant, that means the right hypochondrium. Okay, so when we are palpating the right hypochondrium or upper quadrant, right upper quadrant, and the patient is asked to inspire during that condition, and during inspiration if there is sudden sharp pain to the patient, then this means that the Murphy's sign is positive and that there is a total chances of cholecystitis condition. Okay, so Murphy's sign is very important point here. In Murphy's signs, we palpate the right upper quadrant or right hypochondrium at the tip of the ninth rib. At the tip of the ninth rib, as you can see here, this is the ninth rib. So at the tip of the ninth rib in the right upper quadrant, right hypochondrium is palpated and the patient is asked to inspire, and during inspiration if sudden sharp pain occurs, it means Murphy's sign is positive. Next is cholelithiasis. Cholelithiasis means stones in the gallbladder. Okay, gallstone condition is called as cholelithiasis. It typically occurs in fat, fertile female of 40, which is commonly called as 4F. It is again most important thing you have to keep in mind, that it is typically or most commonly occurs in female of 40 age, fat female, and also in fertile female. It also occurs in male, but it is very rare in males because the hormonal physiology that is happening in the female is not present in the male. That's why it mostly occurs in female. So why it is common in female? Because estrogen level in the female body increases the cholesterol secretion into the bile, and when there is extra of cholesterol or maximum cholesterol into the bile, there is supersaturation of bile. The bile is less and the cholesterol is high. There is supersaturation of bile and it will lead to the precipitation of cholesterol, because as there is less bile as compared to the cholesterol, the bile is not able to absorb that cholesterol, which will lead to the precipitation of cholesterol into the stones. Okay, and it will lead to the condition of gallstones in the gallbladder. Okay, and during in fertile female, during pregnancy, we know that there is high level of estrogen and also high level of progesterone. So high level of estrogen causes high cholesterol in the gallbladder, and high progesterone level causes sluggish emptying of the gallbladder. Because of estrogen there is high cholesterol, because of estrogen there is high cholesterol in the gallbladder, and because of progesterone there is sluggish emptying, that is the bile is not emptying or releasing from the gallbladder properly, and there is a bile stasis condition due to the high progesterone, which will lead to the precipitation of cholesterol and formation of the gallstones. Okay, and in fat women, so obesity increases hepatic cholesterol synthesis, which will lead to more cholesterol which is secreted into the bile, and there is again supersaturation of bile, then precipitation of cholesterol and lead to the formation of gallstone. And in the age of 40, especially in the age of 40, there is less bile production, means there is less ability to dissolve cholesterol in the gallbladder. So if there is high cholesterol in the bile or gallbladder, because of the less bile present in it, there is less ability to dissolve that cholesterol, and the also gallbladder motility weakens, which causes the sluggish emptying of that cholesterol and bile, which will lead to the precipitation of cholesterol and formation of the gallstone. That's why it is mostly common in fat fertile female of 40. Okay, here in this condition biliary colic is present, and Murphy's sign is of great diagnostic value here. Here also Murphy's sign is very important, just like cholecystitis. Next one is cholecystectomy. Cholecystectomy is the operation for removal of gallbladder. Okay, it is the operation for removal of gallbladder. Its indications are cholelithiasis, cholecystitis. We have already discussed these two conditions. In gallbladder polyp also cholecystectomy is done. Polyp is the abnormal tissue growth in the inner lining of the gallbladder, and also in gallbladder cancer there is a need of cholecystectomy. So there are two types of cholecystectomy. The first one and the most common one is the laparoscopic cholecystectomy, which is also called as keyhole surgery. It is the most common, and in this operation or in this surgery, multiple small incisions are given in the abdomen region, and the laparoscope is inserted into it and the gallbladder is removed, and there is faster recovery in laparoscopic cholecystectomy as compared to the open cholecystectomy. Okay, open cholecystectomy is very less common, and there is large incision under right ribs are taken. Okay, in laparoscopic small incisions or keyhole incisions are taken, and in open cholecystectomy large incision under right ribs are taken, and this open cholecystectomy is used only when laparoscopic is not possible. Okay, next one is the Courvoisier's law. What is Courvoisier's law? So Courvoisier's law states that in a patient with obstructive jaundice, if there is a patient of obstructive jaundice, a palpable and non-tender gallbladder is present. If in a patient of obstructive jaundice, a palpable but not tender gallbladder is present, it is unlikely due to be the gallstone, and is more suggestive of malignant obstruction. Okay, if there is a palpable and non-tender gallbladder in a patient of obstructive jaundice is present, there is more suggestions or it is more suggestive of the malignant obstructions other than the common gallstone. Okay, there is a dilatation of gallbladder, as you can appreciate here, the gallbladder is dilated, and on palpation it is non-tender, and the condition is obstructive jaundice. So this thing suggests that there is a malignant obstruction or any malignant causes, and it is not due to the gallstone. It occurs in extrinsic obstruction of the bile and not in intrinsic obstruction. This also means that there is something outside the liver which is malignant cause and not some obstruction which is occurring inside the liver. Okay, and it is mostly commonly seen in the CA of head of pancreas. Okay, in the carcinoma of head of pancreas, as there is CA of head of pancreas causes common bile duct obstruction, which will lead to the obstructive jaundice, and there is the clinical sign present which is Courvoisier's law, and both of these things suggest that it is the malignant cause or it is the carcinogenic condition. Next one is most important structures which is very important during the surgery. First one is the Calot's triangle and second one is the hepatobiliary triangle. So Calot's triangle, what is Calot's triangle? Let's understand its boundaries first. So Calot's triangle is formed medially by common hepatic duct. We can appreciate here in this picture. So this is the common hepatic duct. This is the common hepatic duct. So medial boundary is formed by common hepatic duct. Lateral boundary is formed by cystic duct. You can appreciate here, this is the cystic duct. So it is forming the lateral boundary. And superior boundary is formed by the cystic artery. You can appreciate here, this is the cystic artery. So superior boundary is formed by the cystic artery. So the triangle which is made here is called as Calot's triangle, and the second one is the hepatobiliary triangle. So its two boundaries are same, which is medial and lateral. Medial and lateral boundary are same as that of the Calot's triangle, that is medial boundary is common hepatic duct and lateral boundary is cystic duct. Okay, but the difference is the superior boundary. The superior boundary of hepatobiliary triangle is formed by the inferior surface of the liver. As you can appreciate here in this picture, the superior boundary of hepatobiliary triangle is formed by the inferior surface of the liver. So this triangle which is formed here is called as hepatobiliary triangle. And why both of this triangle is very important during the surgery, during especially laparoscopic cholecystectomy, because it is used to identify and ligate the cystic artery here. Okay, the most important structure here is this cystic artery. So to identify and ligate this cystic artery, both of this triangle is very important, and both of this triangle is located during the cholecystectomy surgery, and the cystic artery is identified and ligate to prevent the hemorrhage during the surgery. So that's all for today's lecture. I'll see you soon in the next lecture with a new topic. Until then, keep reading and don't forget to subscribe, like and share. Thank you for watching this video.